Welcome and thank you for joining us for this webinar presentation. We are the Homeland Defense and Security Information Analysis Center, or HDIAC, one of 3 IAC domains in the DoD Information Analysis Centers operating under the Defense Technical Information Center, DTIC, within the Office of the Undersecretary of Defense for Research and Engineering. Our informative webinar series highlights current and emerging research and technology developments. It presents an opportunity for accelerating the DoD's leverage of these advancements by increasing awareness and fostering technical collaboration. HDIAC serves as one of the premier information research partners and curators of technology advancements and trends for the Homeland Defense and Security community. As such, our organization supports those working in the Homeland Defense and Security domain of DoD research and engineering. We do so by helping navigate the vast landscape of scientific and technical information, allowing our customers to get a head start on their technical projects. With an understanding of the Homeland Defense and Security DoD research and engineering landscape, we provide research and analysis services. We help unlock access to information, knowledge, and best practices from government, industry, and academia to stimulate innovation, foster collaboration, and eliminate redundancy. We hope you enjoy this webinar presentation and that it serves as a catalyst for community collaboration and improved DoD Homeland Defense and Security research.
Okay, good day, everyone. My name is John Clements, and I am the technical lead for the Homeland Defense Security Information Analysis Center. And we are happy to provide you with this second part of our Brain Health mini-series webinar presentations. Before I get started, introduce the webinar, just a few administrative comments. First of all, the presentation is available online or will be very, very shortly. You can go to the webinar registration site at hdIAC.org/webinars. If you click on today's webinar, you'll be able to download it and you'll have a PDF copy of the presentation. If it's not there, just wait another minute. We had some technical difficulties getting it to the site, so it should populate any second now. There will be a Q&A session at the end. The best way to ensure that I get to your question is to click the 3-dot ellipses menu in the bottom right-hand corner, and you'll see a selection for Q&A, and just drop your question in there, and that'll ensure that I get to it. I'll also be monitoring the chat, so if you put your question there, I should be able to get to it. But the best way to ensure it gets there is to use that Q&A function. With that, I'd like to welcome you all to part 2 of HDIAC's Brain Health mini-series. We're presenting this mini-series in addition to our regularly monthly webinars. The goal is to highlight the tremendous amount of research into the health of the brain, the most complex organ in the body. Decades of research by thousands of people worldwide has led to an increased understanding of how the brain functions and how it impacts our operation when it is injured. However, with each answer, it does seem that multiple new questions arise. Part 1 of the mini-series started in the beginning discussing the SABRS program and baselining for the brain. If you missed that, you can check it out on our YouTube channel. Part 2 today will explore the mental health of soldiers and their families who have not deployed and may suffer sort of from a type of survival skill. May being Mental Health Awareness Month, and this will examine a longitudinal study done with hundreds of soldiers and their spouses, and notably all the soldiers were guardsmen, I believe, at least definitely for reserve component, but Dr. Hoopsick will go through that. On June 14th, we'll welcome back our presenters from the first presentation, Drs. Baer and Starnes, to discuss neurofeedback and methods to modify brainwave activity to benefit the warfighter. And on July 17th, we examine methods of using cognitive and ocular motor functions to assess service members who have suffered a traumatic brain injury. And if one of those dates does not work, you can always catch them on our YouTube channel, and the slide presentations will be posted to the HDIAC website with the announcements once they are ready. So without further ado, I would like to introduce today's webinar and presenter. Today's webinar is Never Deployed, but Still at Risk. Substance Use and Mental Health Problems Among Reserve and Guard Soldiers. It was presented by Dr. Rachel Hoopsick, and she was the first to come on board with this idea of a brain health mini-series. So we've actually been communicating a little bit back and forth, I think since about September. So this has been a long time coming. So thank you, Dr. Hoopsick. She is an assistant professor in the Department of Kinesiology and Community Health at the University of Illinois Urbana-Champaign and co-investigator on the Operations Safety Study. She uses epidemiologic methods and socio-ecological lens to understand risk and resilience for problems with substance use and mental health among populations with high stress occupations and life circumstances. Her research has primarily focused on military populations, including veterans, active duty service members, reservists, and military connected families, with a focus on never deployed service members and veterans, a population at increased risk for problems with substance use, mental health, and barriers to healthcare services, yet one that remains understudied. Dr. Hoopsick holds an MS in epidemiology, an MPH in health service administration, and a PhD in community health and health behavior from the University at Buffalo. And Dr. Hoopsick, I will turn it over to you.
Perfect. Thanks so much, John. I'm going to go ahead and share my screen here. All right. Can folks see my slides?
Yes, I can see them.
Perfect. All right. Thank you so much for having me today. I'm really excited to talk to you a bit about some of the research that our team has been conducting, including our cohort study with the Operation Safety Sample. So today I'll walk you through my perspective to research regarding military connected populations and tell you a bit about some of the specific studies that we've published. I'd like to begin with a disclaimer, especially for this crowd. I do not have lived experience as a military service member, but I do deeply care about military connected populations. I myself have several family members who've served in the military, and my husband works for the VA. Some of my work that I'll be talking about today was actually inspired by someone close to me who experienced a pretty severe injury during a training exercise early in his military career. And as a result of that injury, he was never deployed. But despite never deploying, he's experienced substantial problems with substance use, mental health, and really just making sense of his identity and what it really means to serve your country. So just as a broad kind of overview, my program of research examines the intersection of substance use and mental health and factors that contribute to people's risk and resilience for adverse outcomes, as well as the environmental contexts that shape people's behaviors, relationships, and health, right? It's all dynamic. We don't live in a bubble. So the ultimate goal of my research and what our team does is to inform the development of new and optimization of existing prevention and intervention efforts to improve health among high-risk populations. So I have a particular interest in examining these types of relationships among people with high stress occupations and life circumstances. And as such, much of my work has focused on military connected populations. So as John mentioned, my research brings a socio-ecological perspective and epidemiologic methods to understanding people's risk and resilience for problems with substance use and mental health. So people don't live in a vacuum, and it's important to consider multiple levels of influence, how these levels impact each other, and then the various resiliency factors and stressors that might arise over the life course at any of these levels. So individuals are shaped by their environments, and environments are shaped by individuals. It's a really dynamic process. Much of the research on substance use and mental health in adult populations really tends to focus just on that center individual level risk factors. But we really need to consider a broader range of risk and protective factors, including the social environment. So I'm interested in not only our individual level factors, but also our relationships with other people and broader influences from the organizations that we belong to, the communities that we live in, and the greater societal influence on behaviors and psychiatric outcomes over time. So military connected populations, as we all know, are incredibly resilient, but we do know that compared to the general population, that these folks are at increased risk for poor health outcomes, including substance use and mental illness. We have a wealth of research that demonstrates that combat deployment is a major risk factor for problems with alcohol and other substance use, anger and aggression, and mental health symptomatology like anxiety, depression, and post-traumatic stress. So we know, let's put this into context now, that military populations do indeed have this high stress occupation with significant demands over which folks often have very little control. And so we can also view this population through that socio-ecological lens to better understand their risk for problems with substance use and mental health. So some service members have experienced early adversity, including financial instability, and for some people, joining the military may provide a means out of poverty. People in the military also report a higher prevalence of childhood trauma than the general population. Service members also report having a great deal of family stress, and support from their loved ones and unit members has actually been shown to be a really important factor for promoting good mental health. Service members also live and work within the context of military culture, which can affect both their risk and resilience to adverse outcomes. Community resources are also important when we think about access to high quality care and broader societal contexts like current events that service members are affected by, including perhaps being mobilized to respond to social unrest, assisting with COVID-19 response efforts, border missions, geopolitical events. All of these influences are particularly important during times of transition, like joining the military, leaving the military, deployment, and reintegration, which can all be incredibly stressful. So within military populations, there is significant heterogeneity, right? So service members are not a monolith. Reserve and Guard service members comprise nearly 40% of the U.S. Armed Forces, and they have been increasingly relied upon in the post-9/11 era, yet they really remain understudied. These part-time service members actually have a higher prevalence of substance use disorders than full-time active duty service members and are at greater risk for post-deployment problems with substance use and mental health. So unlike active duty service members who are out living on a military base with other service members, other military families, these reservists often live out in the community, often very geographically dispersed from one another, and oftentimes have fewer supports and resources available. And this part-time service tends to lend itself to very unique family, financial, and identity stressors, particularly when you consider the duality of straddling civilian roles and responsibilities with military roles and responsibilities. So although the overwhelming majority of military research regarding substance use and mental health focuses on the context of deployment, combat deployment specifically, many reservists never deploy during their military careers. And despite most military research and interventions focusing on those who have experienced combat deployment, there's some limited evidence that suggests that there may not be a difference between never deployed and previously deployed service members in substance use disorders, and suicidal ideation. And even on top of this, emerging literature now points to a greater risk among never deployed service members for depression and death by suicide. So I just want to briefly highlight here a study of more than 1 million veteran records demonstrated a significantly higher risk of death by suicide among veterans who served during the Iraq and Afghanistan wars, but were never deployed, as compared to their counterparts who served during the same time period, but were deployed to an active war zone. So we have a small but growing body of research suggesting that folks who have never been deployed and folks who have been deployed are perhaps more alike than different, and we actually have some unique risks among those who have never been deployed. So there are some pretty notable gaps in the literature regarding substance use and mental health in military populations, with really large deficits in information regarding reservists or part-time service members who've never experienced deployment, and of course among female service members as well, because they're frequently excluded from military research. Further research on substance use and mental health that includes these subgroups can help to identify unique factors that affect service members' risk and resilience for problems with substance use and mental health, and ultimately can inform more effective intervention efforts for military populations as a whole. So given the increased risk for problems with substance use and mental health among reservists, and there are really unique stressors that contribute to that risk, a major project that I'm involved with is Operation Safety, which stands for Soldiers and Families Excelling Through the Years. So I'm a co-investigator on this ongoing study that is survey-based, and it's a study of U.S. Army Reserve and National Guard soldiers and their partners, which has been funded by the National Institute on Drug Abuse under the National Institutes of Health since its inception. A total of 418 couples or 836 participants were enrolled in Operation Safety beginning in 2014. So as I mentioned, this is an ongoing study. It is a multi-wave study with yearly assessments. And by including both the service member and their partner, the broader Operation Safety study explores the health and well-being of military families from a socio-ecological perspective, recognizing that our behaviors influence our partners' behaviors and vice versa. So in order to be eligible for inclusion in Operation Safety, the couple needed to be married or living as if married at baseline. And the reason, of course, for this inclusion criteria was that this was a study of military couples, but I want to point out that the majority of U.S. service members are married. These folks needed to have at least one member of the couple be a current U.S. Army Reserve soldier or National Guard soldier at baseline. The soldier needed to be between the ages of 18 and 45 at baseline. Both partners needed to be able to speak and understand English and be willing and able to participate. And our final criterion for inclusion was that both partners needed to have at least one alcoholic beverage in the past year. And the reason for this inclusion criterion, first, was that this is a study focused on substance use, and we know that people who tend to abstain completely from alcohol tend to be also quite different in many other health behaviors than non-abstainers. So taking a look at the characteristics of the soldiers that we enrolled in Operation Safety, they were predominantly male in their 30s and with some college education. Operation Safety is comparable to National Reservist estimates, including the proportion of women, and our sample was fairly racially and ethnically diverse. So, given the dearth of research on never deployed service members and reservists generally, a central component of the research that I've done with Operation Safety over the last few years has been to further examine the role or lack thereof that deployment plays in substance use and mental health problems among these part-time service members. Now, much of the research is data heavy, so I'll do my best to orient you to what you're looking at and to make sure you understand the main takeaways. So using data from Operation Safety, we first aimed to determine if there were differences in our soldiers' substance use, mental health, and potential protective factors on the basis of deployment history. And we also wanted to understand if deployment status, mental health, substance use, and resiliency factors tended to track together as what we call a latent construct affecting psychosocial health. So here's what we are looking at here. We have a range of factors, including substance use, mental health, and some protective factors, including psychological hardiness and marital satisfaction. And we took a first look at some descriptives according to whether the service member had been deployed or had never been deployed. And we're examining for statistically significant differences. So when we examined soldiers' mental health, substance use, and resiliency by deployment status, we found that never deployed and previously deployed soldiers were really much more alike than different. And in fact, these soldiers only significantly differed in their mean post-traumatic stress symptomatology. And then when we further broke that down, there was no difference in terms of meeting criteria for probable PTSD or meeting the threshold for clinical PTSD. So really more alike than different within our sample of reservists. So using next a structural equation modeling approach, we found that all of these factors significantly contributed to a latent construct that we've called psychosocial problems, where they tended to track together. Using standardized factor loadings, which allowed us to make some comparisons, we saw that the mental health and substance use variables all positively loaded onto our latent construct or were associated with greater psychosocial problems. While conversely, those resiliency factors of psychological hardiness and marital satisfaction negatively loaded onto or were associated with less psychosocial problems. But lastly, we see that deployment status was the least salient factor in the model. And so this was our major takeaway here. So these findings are telling us that deployment status, so whether you've been deployed, yes or no, in and of itself is really a poor predictor of psychosocial problems among reservists, which is particularly important given that most of our interventions aimed at identifying and addressing these problems have primarily focused on service members who have experienced combat deployment. So this study first highlights how individual and interpersonal factors are more important to understanding psychosocial problems in some military populations than the deployment experience alone. So in a subsequent study within Operation Safety, we aimed to examine the relationships between several intrapersonal and interpersonal resiliency factors and mental health outcomes. So these potential resiliency factors included the support that soldiers received from their military units, their marital satisfaction with their partner, and their psychological hardiness. And in case I haven't defined that yet, psychological hardiness is really our tendency to have an attitude and worldview that puts stressful life events into perspective, perceiving them as less of a threat and more of a challenge, and really view these events as opportunities for personal growth. So we examined the relationships between these factors and several mental health variables, including anger, anxiety, depression, and post-traumatic stress symptomatology. And then secondarily, we wanted to take a look and see if any of these relationships differed for never deployed and previously deployed soldiers. So given that we have some overlapping symptomatology and shared variants of some of the mental health outcomes, we used a multivariable path analysis approach here to examine really the simultaneous effects of these different resiliency factors on all of those mental health outcomes. And so first we found that greater unit support or perceived support from military unit members was associated with less anger, less anxiety, less depression, and less PTSD symptoms. And likewise, we also found that stronger or greater marital satisfaction with the soldier's partner was also associated with less mental health symptomatology. So less anger, less anxiety, less depression, less PTSD. And similarly, We also found that greater psychological hardiness also appeared to be a significant protective factor when we're talking about mental health. However, when we examined for interactions between these resiliency factors and deployment status on mental health, we found 3 statistically significant interactions. So deployment status modified the associations between psychological hardiness and anxiety, depression, and PTSD. And on the next slide, I'll show you a little bit more about what these 3 interactions mean. So to further understand what was happening, we probed each of these interactions by examining the conditional effects of psychological hardiness on each of these mental health outcomes by deployment status. So here I'm showing never deployed soldiers in blue and previously deployed soldiers in this reddish orange color. And in all 3 cases, what we found is a similar relationship. That greater psychological hardiness was associated with less mental health symptomatology, but the effect was even stronger for soldiers who had never been deployed. So given that our previous study showed similarities in psychiatric outcomes between never deployed and previously deployed soldiers, the findings of this study are important because they demonstrate now that there are also modifiable factors at the individual, interpersonal, and at the military organizational levels that might be protective for service members in the development of poor mental health. And importantly, in the context of my work, that some of these may be even more salient for folks who've never been deployed. And this is a group that receives currently very little attention or support. So in addition to some of the work that I've done with Operation Safety, I've also used an assortment of large public data sets in my research as well. So for example, I've leveraged the National Survey on Drug Use and Health, or the NSDUH. So this is a large nationally representative survey regarding substance use and other health-related topics. So the NSDUH has been administered biannually since 1971 and every year since 1990. And this is administered by SAMHSA, and it uses computer-assisted self-interviewing methods. So each year when the NSDUH is collected, the sample size tends to be quite large, often exceeding 60,000 people each year, including people from all 50 states and Washington, D.C. So I will be going into some research, still talking about our military connected populations, but leveraging now data from the National Survey on Drug Use and Health. So although our previous data suggests that soldiers who have and have not been deployed are more alike than different, this for most people often goes against conventional wisdom, right? The idea that being deployed is this primary catalyst for problems with substance use and mental health. That idea is really pervasive. So I was interested in understanding if veterans' likelihood of reporting having been asked about their alcohol use by a healthcare provider in the last year, and their likelihood of meeting clinical criteria for alcohol abuse and dependence differed based on their service history. So using a large sample of pooled cross-sectional data coming from the National Survey on Drug Use and Health, we restricted our sample to veterans who reported having at least one visit with a healthcare provider in the past year. We used logistic regression models to examine the effects of veterans' history of active duty service or activation, like a deployment, on several outcomes. So we looked at past year alcohol screening by a healthcare provider, or in other words, did a healthcare provider ask them about their alcohol use? And then 2 more clinical outcomes, looking at if the veteran met DSM-4 criteria for past year alcohol abuse or past year alcohol dependence. And we controlled for demographic factors that might confound the associations between military history and these alcohol outcomes, including age, sex, race, ethnicity, family income, and whether or not the veteran had health insurance. So what we first found was that veterans' history of active duty service or activation was associated with the likelihood of past year alcohol screening, with veterans reporting a history of either being active duty or having been activated, being more likely to have been screened in the past year by a healthcare provider. However, when we examine veterans' likelihood of meeting clinical criteria for alcohol abuse and alcohol dependence in the past year, which was assessed by a series of screening questions in the NSDUH, we found that there were no significant differences in alcohol abuse or dependence by military history. So these findings, using a large national data set, are beginning to mirror some of our previous findings, that service members' problems with substance use is largely the same, regardless of military history. However, the results from this study suggest that healthcare providers may be actually less likely to screen certain veterans, particularly those who served part-time in the military and were never deployed. So I think this particular study is important because it demonstrates that even after we consider individual level differences between service members on the basis of their military history, there are gaps in healthcare providers' knowledge regarding military populations that is likely informed by these false narratives that deployment is that primary catalyst for substance use problems in military populations. And this bias might result in under-screening, under-treatment, and perhaps worse health outcomes for veterans who were never deployed. Although I don't have slides on it here, I am currently working on a follow-up study looking at the healthcare preferences and experiences of service members, and we found that service members who were never deployed were less likely to report being asked about their service or how their service affects their health by their healthcare providers. And moreover, never deployed service members were also more likely to prefer receiving their care outside of the VA. So with a civilian provider in a community setting. But despite this preference, never deployed soldiers had very low confidence in their civilian healthcare providers' understanding of their needs. So I think that this is starting to highlight the importance of being competent in military culture, even when patients have never been deployed. So what is next? Given the results of the few studies that we've talked about so far today, we now know that never deployed and previously deployed soldiers are both at significant risk for problems with substance use and mental health. While the effects of combat exposure on these outcomes has been well explored among soldiers who have been deployed, it's really less clear why service members who have never been deployed also have these problems. So another important component of my work has been to understand how soldiers feel about never being deployed and whether or not these emotions might be contributing to their substance use and mental health outcomes. After having multiple recruiting events for Operation Safety canceled, all due to suicide deaths among never deployed soldiers within those units, we began exploring this idea of non-deployment emotions. So based on participant feedback and some of our prior research in other populations, we thought that some of these never deployed soldiers might be experiencing feelings similar to a survivor's guilt, or they may be perhaps experiencing some social separation from their unit members. So while reservists who do deploy might spend, like a year or more with their unit, those who never deploy only spend a few days of training and monthly weekend drills with their unit each year. So here we really sought out to test a new measure of non-deployment emotions and examine its relationship with mental health symptomatology. So we developed the non-deployment emotions questionnaire, which was a simple 4-item measure assessing soldiers' guilt for never having been deployed, as well as feeling like they are less valuable, have less camaraderie, and feel less connected with their unit for never having been deployed. And responses ranged from not at all to extremely, and this measure showed good internal consistency with our sample. We conducted a latent class analysis to examine for unique or distinct levels of non-deployment emotions, and our model fit statistics suggested that there were 3 unique classes representing low, moderate, and highly negative non-deployment emotions. So next, we examined the relationships between non-deployment emotion score and anger, anxiety, depression, and post-traumatic stress separately using negative binomial regression models to really better understand just the face validity of this measure. So we controlled for the soldier's years of military service, the number of friends that the soldier reported in their social network who are also in the military, their marital satisfaction, as well as their sex. In our unadjusted models, the worse that a soldier felt about never having been deployed, the worse their mental health symptomatology. Our adjusted models showed a similar effect. So again, greater non-deployment emotions were associated with worse anger, anxiety, depression, and post-traumatic stress. So this initial validation of our novel measure of non-deployment emotions was important because it demonstrates that soldiers' emotions related to never having been deployed, which are shaped by individual, interpersonal, and organizational factors, are associated with a range of mental health symptoms, which may partly explain why some service members who never experienced deployment are affected with problems with their mental health. So given the findings of that previous study, we thought then it's important to understand if non-deployment emotions are associated with other psychiatric outcomes. So in this study, we aim to examine the relationships between non-deployment emotions and a range of alcohol use outcomes, as well as to examine for potential differences in these relationships by sex, given that there are some really notable differences in drinking behaviors of men and women in the general population. So what we took a look at here was the relationships between non-deployment emotions and a range of alcohol use outcomes, including hazardous drinking, the frequency of getting drunk, the typical number of drinks consumed during a drinking episode, and the percent of days spent drinking over the last year using negative binomial and fractional regression models. In our unadjusted models, greater non-deployment emotions were associated with more hazardous drinking, a greater frequency of getting drunk, a greater number of drinks consumed during a drinking episode, and a greater proportion of days spent drinking. After controlling for some factors that might confound the relation between non-deployment emotions and alcohol use, including years of military service, the number of friends that the soldier identified in their social network who are also in the military, the soldier's marital satisfaction, and their depressive symptoms, we still see that greater non-deployment emotions were significantly associated with hazardous drinking, the frequency of getting drunk, typical number of drinks consumed during a typical drinking episode. When we take a look at the interaction effects of non-deployment emotions and sex on alcohol-related outcomes, or in other words, does the relationship between non-deployment emotions and alcohol differ according to sex, we see that there was a statistically significant interaction for hazardous drinking. So here we see that there was no relationship between non-deployment emotions and the predicted probability of hazardous drinking among female soldiers, but among male soldiers, as non-deployment emotions increases, the predicted probability of hazardous drinking increases. While the other interactions for the other alcohol-related outcomes weren't statistically significant, they were consistent in magnitude and directionality, suggesting that perhaps if we had a larger sample, we might see similar effects for other drinking-related behaviors. However, as I mentioned at the beginning of this talk, never deployed service members are pretty infrequently recruited into research, and so one of our recommendations is to continue to study this group with other samples. So the findings here are important because they highlight a possible explanation for some risky drinking behaviors among soldiers who've never been deployed. And that interaction by sex suggests that we may need more targeted interventions among male soldiers who have these negative emotions related to never having been deployed, which again are shaped by individual, interpersonal, and organizational factors. In this last study that I'm sharing with you today, we aim to examine if the findings from our previous cross-sectional research extended to other substance use and over time. So we examined the longitudinal relationships between non-deployment emotions and several drug use outcomes across 3 time points that we assessed over a 2-year period. We also wanted to explore again, if these relationships differed for male and female reservists. We used GEE models here to examine the longitudinal relationships between non-deployment emotions and soldiers' current tobacco use, soldiers' non-medical use of prescription drugs, or what we have abbreviated here is NMUPD, and soldiers' current illicit drug use over time. And I just want to define the non-medical use of prescription drugs in our study was defined as using a prescription drug that is either not prescribed to you or is prescribed to you, but you are using in greater amounts, more frequently, or for a reason other than as prescribed. In our unadjusted models, the worse that soldiers felt about never being deployed, the greater their likelihood of non-medical use of prescription drugs and illicit drug use over time. After controlling for soldiers' depression and whether or not they were still currently serving in the military, because again, this is a longitudinal cohort study of reservists. So one thing that inevitably happens is that folks leave the military during the course of the study, but they remain in our study. So we wanted to make sure that we were controlling for the effect of leaving the military. But after we did that, our main effects were no longer significant. However, given that our prior work had showed an interaction between non-deployment emotions and sex, there could be a similar interaction being obscured here by looking at male and female soldiers together. So when we added an interaction term for non-deployment emotions and sex to the final models, we see that there was a significant effect on current non-medical use of prescription drugs. And when we examine that further, we see that among male soldiers, greater non-deployment emotions were associated with a higher likelihood of current non-medical use of prescription drugs, but no relationship between non-deployment emotions and substance use among women. So these findings from this last study are important because they show that non-deployment emotions, again shaped by individual, interpersonal, and organizational factors, may contribute to ongoing substance use among male service members who have never been deployed. So the reserves represent, I think, a high-risk population that is, of course, now expected to grow. But our program of research suggests that never deployed and previously deployed soldiers are both at risk for problems with substance use and mental health. Our measure of non-deployment emotions was associated with mental health symptoms and substance use, with both cross-sectional and longitudinal evidence suggesting that this brief questionnaire may have some clinical utility, complementing existing screening measures to help identify service members who are at risk for poor health outcomes. And it should also be noted that this body of work highlights the need for military competent care for all service members. Yet reservists who never deploy currently remain ineligible for benefits under the U.S. Department of Veterans Affairs. And so this work could inform changes to that policy. A focus of my training has also been on implementation science and translational research. So extending these epidemiological findings to practical interventions would be an area for future research and of course, potential collaboration. Our work in sum, I think, suggests that intervention and prevention strategies should go beyond addressing individual risk factors by using a socio-ecological perspective. So we really need to consider how military service, whether it is full-time or it is part-time, can affect health in ways beyond just combat deployment. In conceptualizing how we address the needs of never deployed folks, I think that some of my research has shown we will likely need to consider multiple levels of influence and approaches to prevention and intervention. Thank you so much for all of your time and attention today. Before I finish, I wanted to acknowledge my collaborators, funding sources, and the research staff and participants for whom none of this work would be possible. And if any of this resonated with you, I'm always looking for research collaborators. So please keep in touch with me. I am also happy to answer any questions you might have as well. Again, thank you so much.
Thank you so much, Dr. Hoopsick. That was an impressive presentation on something that has been definitely understudied. I do have a couple questions I want to start off with, and I'll just remind folks that on the bottom right-hand side of your screen should be an ellipses menu with a Q&A function where you can put your questions in that I can ask Dr. Hoopsick. But I'll get started with these first couple that I have here. Just a question. I apologize if you went over this in the briefing already, but how did you guys score marital satisfaction? Like I know a lot of this stuff was survey based, but like was that a more extensive survey to gauge satisfaction, or was it just kind of a simple rating by the service member and their partner, or how did you score that?
Sure. So we had a validated measure called the marital adjustment test. So this is actually a pretty old measure used in a lot of couples research, but it asked a lot of questions about people's satisfaction in their relationship with their partner. And what we did is we administered it to both members of the couple. So we asked the soldier about their satisfaction with their partner. And of course, we also asked the partner about their satisfaction with their soldier. And in some cases, we had dual military couples as well, just to sort of clarify that. But we did use a validated measure that has several subscales related to military satisfaction. So much more than a single question of, are you happy with your partner?
Okay, and you just answered the first part of the next question, which was, did you have any dual military couples? And you just mentioned that. Were there any differences in the results for the dual military couples?
The dual military couples were a fairly small proportion of our sample as compared to, a military civilian dyad. But we do have one of our collaborators on the team looking into some of the unique attributes of some of our dual military couples. And they're looking really at how some of the stressors are intensified for those couples. It's not been a focus of my research, but we do have someone on our team taking a look at that. Something else that's also interesting within our sample that we haven't been able to do too much with because of the sample size is we also have a small number of same-sex couples in our sample as well. So the overwhelming majority of folks in our study were in male-female relationships, but we do have several same-sex couples. And so from a quantitative perspective, we haven't been able to do too much with looking at differences there, but that is certainly something that is ripe for qualitative exploration.
Yeah, thank you so much. And another question just came in. Do you know if there will be a similar study to examine Air Force Reserve and Air National Guard members?
We don't have one yet, but I think it would be great. You know, perhaps if maybe DoD wants to fund us for that, we would love to do that.
Okay. I'm just looking through some of the chat.
Sure.
So I'll take this moment to remind everybody that HDIAC exists to support the scientific and technical community. So if you have questions on this or related topics, or really any topic that is of interest to the military community, which includes pretty much any medical topic you can think of, because service members and their families are all supported by the DoD and have the same types of problems and issues as the regular population. But you can reach out to HDIAC. You can go on our website and register for an account and submit a technical inquiry, and we do research on the behalf of anybody that has supported government research. So that includes contractors. And but with that, it doesn't look like any other questions have come in. But so, Dr. Hoopsick, thank you very, very much for this incredibly informative presentation. And as I said, this will be up on our YouTube channel probably by tomorrow, if you want to share it out. And and I look forward to continuing this brain health mini series. Thank you so much.
Thank you so much for having me. It was my pleasure. Folks can feel free to keep in touch with me by email as well. Thanks again.
Great. Thank you.